It's actually the same number of in utero transmissions, but the total number of transmissions has shrunk so much. So the pie has gone down to only 6 or so transmissions a year. The slice of the pie that's associated with in utero has just gotten bigger because we're really impacting on a lot of those peripartum transmissions. So this is the nut that we still have to crack, try to get a hold of these and identify the women who might be at risk for in utero transmission. The algorithm for testing in pregnancy, you want to get the prophylaxis during pregnancy, during labor and delivery, and postpartum to the baby, all 3 components. The best way to do that is screen at the first trimester, repeat screening in the 3rd trimester. If they haven't had these testings done, then you can do an expedited testing in labor and delivery. If that's missed, then at birth or to the infant, but these obviously don't allow the first 2 components of preventive therapy to be given. So we really want to make sure we screen the women early. During the syndrome, of course, we'd look for what we talked about, EBV, CMV, RPR, but don't forget about acute HIV. Now, it's important that we recognize this syndrome because women might be in this window period where they're antibody negative. And if you have a high suspicion, as I was telling you, that this acute syndrome could be HIV, maybe a person who's had risky behavior, rape. I just got back, last week I was in the baths and I had a lot of risky sexual behavior, and they have the right clinical syndrome. Do the RNA screening in that setting, and that's one time we did want to do, let's say, the Aptima test. Okay, so once a person is confirmed with acute HIV, you must link them into specialty care. Prevention counseling is critical because there's a high rate of transmission during this period. Work on partner notification. This is a time when it's important to raise these issues. The person's getting this information. You might be able to get information, in a readily way while it's still fresh in the mind. Who might I have had sexual contact with, in the last few weeks? And we do a resistance test. We want to do a resistance test as soon as possible. You may not do it in the emergency room, but we would want to get this testing done as soon as possible once we get them into care. And why? Well, there is the possibility of acquiring resistance, primary drug resistance. So before anybody's even been on treatment, they may acquire resistant virus from the person that they were infected from. And that could, the sooner we can do the resistance testing, the better, especially during pregnancy. We won't wait to initiate therapy in pregnancy for the resistance test, but we will want to get this information as soon as possible to try to modify therapy. And we can see that overall the risk for transmitting resistance is around 16.5%, 17%. It may be higher in areas like New York where there's a lot of antiretrovirals being used in the community. Amongst our classes of therapy, the non-nukes are more likely to transmit drug resistance than the other classes. But if you look in the purple is the overall risk of acquiring resistance. The orange are those people who are recently infected, and the turquoise, I guess, are those who had more long-standing HIV infection. And you can see the orange bars are higher, so you're more likely to detect drug resistance during transmission if someone has recently been infected. So there are 2 possible reasons for that. The first one is that, well, there's just maybe more drug resistance around now, and somebody who's being infected is more likely to pick that up. Although if you look at the data in the last several years, the rate of drug resistance in the community has sort of been stable. The other possible explanation is that if you do this testing for drug resistance early, we're going to catch resistance before the virus has a chance to mutate out of it. So we know that the resistance mutations cost the virus in their ability to grow. And non-mutant virus grows better than mutated virus. So if the virus is allowed to grow for a year or so, there can be back mutations where the resistance mutations could fade into the background. They're still there, but they'll be in a minority population, and our testing just might miss them. So that's why it's so important to test people early, especially if they're getting an acute infection. You're just more likely to demonstrate the resistance that's there before it can fade away to the background. Because it's there, and it's going to burn you if you treat them and you don't recognize that it's there. All right, so during pregnancy, if you can identify an acute HIV infection, all the guidelines say you just start on treatment right away because you really want to bring that viral load down as quickly as possible, primarily initially to prevent mother-to-child transmission, but there may be some benefits to the mom as well, including decreasing the severity of her illness and helping her immunologically. We're going to go through some of those potential benefits in a second. Okay, so the key thing is you have to think about it to be able to diagnose it, use the appropriate laboratory tests that we went through, and we can go through questions on that at the end. And it offers an opportunity to provide prevention, intervention, refer to HIV primary care, and get the person's own heart, especially if they have, if they're pregnant. Okay, another case, this was a really interesting case, and by the way, these are real people. In fact, I saw this kid the other day again. He's a 24-year-old male who presented to the emergency room with daily fevers of up to 103 Fahrenheit for 2 weeks. He had developed bloody mucoid diarrhea for approximately 1 week after the onset of fever that was associated with abdominal cramping, no nausea or vomiting. He reported cough and chest congestion for about 2 weeks and had tender cervical lymphadenopathy. He had no rash, diaphoresis, joint pain, or swelling. His white count was 6.9. He had an absolute lymphopenia of 676, and his platelets were normal. He had some slight elevation in his transaminase 86 ALT, 43 AST, but he had normal bilirubin and alk phos. Maybe not as much as you might see, let's say, with acute Epstein-Barr, etc. He had stool workup for enteric pathogens, ovin parasites, E. histolytica, bloody diarrhea. All that was sent off. I could tell you it was all negative. His serology for Epstein-Barr virus, cytomegalovirus, Babesia, and Ehrlichia was sent. He must have been seen by an ID person. His plasma CMV PCR was also ordered. And again, you wouldn't know it, but all those things were negative. In fact, he had chronic Epstein-Barr. Anal swabs were done for chlamydia to rule out LGV, which we're seeing a lot of proctitis from that. Herpes simplex were also sent off. All that was also negative, by the way. They gave him Cipro and Flagyl, didn't help him. So his HIV ELISA was positive and Western blot negative, so a viral load was sent off, and it was 9.7 million copies. And his T cells were 163, so very low. He was initially started within 3 days. We got him on combo therapy, tenofovir, FTC, and raltegravir. His diarrhea and constitutional symptoms promptly resolved within 4 days, and his viral load had decreased to 10,000 just within 2 weeks, and his CD4 count rebounded up to 552. He then went to become undetectable. He's been undetectable for over a year, and he's got normal CD4 count. He had reported sex with men with a history of several recent casual relationships. He was treated for pubic lice during the preceding summer, had denied any history of syphilis, gonorrhea, or chlamydia. In the ensuing year, he did develop secondary syphilis, so he continued to have ongoing risky behavior even after his HIV was suppressed. He had undergone HIV testing 4 times prior in his very young life, most recently 3 months before this most recent presentation. So you may say, oh, well, he tested HIV recently. That may not be the differential, but it certainly was. In fact, they thought he had inflammatory bowel disease. So why is it so important to diagnose HIV during this acute phase? And this is where the field is really evolving very rapidly. There's so much focus on identifying people in this very early phase. You may have heard about this infant newborn baby that was treated and has a functional cure. And a lot of it has to do with the very rapid intervention during acute infection. So a couple of things about acute infection. We talked about the viral load being so high. So there was a Rakai study looking at discordant couples where one person was HIV infected and the other one wasn't, and the risk of transmitting to the uninfected partner was very much related to the viral load in the blood of the infected person. And it's almost like a dose-response curve. The higher the viral load, the more likely you were to transmit. So obviously, our patients with acute infection are going to be the highest risk. And on average, acute HIV, the average viral load is over 200,000. During established or chronic infection, it's about a log lower, 29,000. The risk of transmission per sexual contact goes up. The viral load in the semen is highest during this acute phase within the first few weeks of infection. Then it sort of settles down into this asymptomatic phase. You'll see some people will say, I've been married to this person for 5 years and I didn't acquire HIV. Well, during this phase, the risk is lower. Also, maybe the longer we're with people without having sex with them, I don't know. But during that phase, the risk of transmission per sexual contact goes down. And then it goes up in the pre-terminal. But here, the people tend to be maybe a little bit symptomatic. They may be too sick to be engaging in a lot of risky behavior. So most of the transmission is happening here, and that's before a person is likely to even know that they have HIV infection. So we can really do something to intervene here. That's 75 to 750 times more infectious during that period. So you can see we can impact on the epidemic if we could intervene at that early phase. And there have been a number of studies that have shown the relative contribution of transmission during the acute phase, and that ranges anywhere from a third to almost half of the total transmissions are attributable to people transmitting virus when they themselves were just very recently infected. Knowledge of HIV seropositivity does affect behavior, so this is another benefit. If somebody knows they're infected, they will reduce their risky or unprotected sexual contact. There's something called serosorting, where if a person knows they're having sex with another person of the same serostatus, but still they will reduce their risk by about half. And then if your partner is of unknown risk HIV status, it's about a 2/3 decrease in risk behavior. So just that knowledge alone can be an important factor in preventing transmission. Now, we have the major treatment guidelines, the International AIDS Society and the DHHS, the Department of Health and Human Services guidelines, are now recommending consideration of initiation antiviral therapy in somebody with acute or recent infection, which is defined as being infected within the previous 6 months. And potential benefits that might be accrued from that is that, we see that the viral load tends to sort of naturally come down after a period of time. But if you can intervene before the infection is suppressed by whatever means, immunologic or whatever, that occurs in the natural history, if you can just draw that virus load down by treating, you will have benefits to the immune system because you'll may be able to prevent the widespread seeding of a lot of T cells with the virus. And as you know, the virus will integrate its genetic material into the chromosome of the cells, and once it does that, those infected cells will remain in the body carrying the virus gene as sort of a Trojan horse for the lifespan of those cells. Now, most of the cells that are infected are rapidly turning over, so the virus will die with them. But there are a proportion of cells called central memory cells that are critical to the function of the immune system. They must remain in the body for life, or their progeny cells will remain in the body for life. Otherwise, we'd all get chicken pox, every time we got exposed. There would be no role for vaccination. It's these central memory cells that must persist. They become sensitized to the antigens of interest, and if you're exposed to chicken pox, they're ready to go. But if they're carrying HIV genetic material inside, when those cells eventually become activated years later, whoop, the virus will pop out from them. And that's the reason why treatment right now is lifelong. So if you can do something at this early stage to somehow prevent the establishment of the infection in these memory cells, or to lessen the spread into these memory cells, you might be able to impact long term.